Okay, so I'd like to welcome you all to NHF's Collaborative Learning Exchange for Clinical Issues in Bleeding Disorders. We launched this education initiative back in spring of this year with a 4-part series on novel non-factor therapies. How do I get, oh, there it goes. Sorry about that. my mouse was stuck. You know, these provider education activities are being jointly provided by the University of Nebraska Medical Center and the National Hemophilia Foundation. Today's learning exchange is focused on VWD diagnostic testing challenges among women and girls and people with the propensity to menstruate. We made a little acronym WGPPM for short. You'll see that throughout the presentation. This program was designed to offer providers and especially prescribers with an opportunity to have peer-to-peer conversations about their challenges to VWD diagnosis and management of WGPPM, those with family history and or with bleeding symptoms. This is my photo. I am the Director of Medical Programs and Information at the National Hemophilia Foundation. My name is Angelina Wong. We have a superb duo presenting today. Dr. Mira Chitler is a pediatric hematologist. She's also the HTC and Hemostasis Director at Children's Hospital of Michigan. She's been in practice for more than 20 years. She also has faculty appointments with the Central Michigan University College of Medicine and Wayne State University School of Medicine. She's been a strong advocate for women and girls and women who have the propensity to menstruate and those with rare disorders. Dr. Veronica Flood is a pediatric hematologist oncologist in Milwaukee, Wisconsin. She also has been in practice for more than 20 years. She's professor and interim division chief of pediatric hem-onc at Medical College of Wisconsin and still sees patients at Children's Wisconsin. She's also one of the main contributors to the International VWD guidelines, which were released last year. This is just a brief overview of what's in store for the hour. Right after the introduction, we'll have the 2 talks with some background on VWD diagnostics, but then we'll also present some cases that we hope very much that you'll participate and share comments on. And then at the very end, we'll be having a Q&A and group discussion. These are the learning objectives, which were also sent in the cover sheet flyer that went this morning by email, just so you have an idea of what content we're planning to cover today. And then, you know, how you can actually participate. You know, this activity was designed to be interactive, to be an exchange among peers. We really do encourage you to share your thoughts on the cases that will be presented. Please use the raised hand function to make a comment. We're also going to be launching a few pre-poll questions to assess everyone's knowledge and considerations in diagnosing VWD. And, you know, there's a chat button at the top or at the bottom, I believe. And, you know, you can use that button to post any questions for the speakers. We'll do our best to cover all the questions, but naturally, due to time constraints, we might need to email some of you afterwards. So without further ado, here's the results of the first few polls. Let's just give that a chance to finish. And please scroll to the 3rd question if you can't see it in your window. So thank you all so much for answering these questions for us. It just helps us to know where everyone is coming from. So without further ado, I'm going to hand off to Dr. Chitler, who will lead the content portion with the pre-analytic variables.
Good afternoon, everyone. I'm Meera Chitler from Children's Hospital of Michigan in Detroit. It's a pleasure today, and I'd like to thank the organizers for giving me this opportunity to speak to you all today. So I've been given the task of addressing two aspects, pre-analytical variables and diagnostic delays. So as soon as we can get to my first slide, we'll start. All right. So I'm going to start with a case presentation just so that we can make it a little more interesting. So you have a 4-year-old little boy who presents to the pediatrician's clinic with complaints of frequent nosebleeds that started when he was 2. He has about 3 or 4 a month. Some of them last as long as 40 minutes, and it happens from both sides of the nose, and it's not really related to change in seasons. He also has complaints of easy bruising, but the mother says that he had no problems with the circumcision. In the family history, the mother has heavy menstrual bleeding and easy bruising, and she's actually pregnant now at 7 months with her second child. So the pediatrician looks at the kid and considers von Willebrand disease as a possible diagnosis based on the fact that he has some bruising and epistaxis, and orders a CBC with diff, a PT, PTT, fibrinogen, von Willebrand activity, and antigen and factor VIII activity. So this child is really anxious. It takes 3 people to hold him down to draw the blood, and they put in a tourniquet. The RN has to poke him about 3 times before she can actually hit a vein and get the blood drawn. So next, please. So here are the results from this child's workup. So you have von Willebrand activity and antigen that's in the 100% range, and a factor VIII activity that's about 95%. So one of the questions we should ask is, how would you interpret these results in the context of the case that I just presented? And also, do you want to check this mom's von Willebrand factor activity and antigen? Do you want to check her factor VIII, given her history of heavy menstrual bleeding and easy bruising? So here's a polling question for you. It's nice to see everybody being involved. Okay. So I guess 80% of the audience said that they would like to check mom's levels, given her history of heavy periods and easy bruising. And a few of you said you don't want to do either of them. So I think the question now is, which is potentially the right answer? And if you chose one or the other, why should you or why shouldn't you do the testing at this point of time, right? So can we go to the next slide, please? Sorry. Okay. So what are all the different things that can affect our results? So when we look at von Willebrand testing, or for that matter, factor VIII activity testing as well, these are what we call acute phase reactants. And so in the event of stress, in the event of other kinds of illnesses, they can acutely be affected. But even taking a step back, so there are several things that we have to take into consideration. What is the patient situation? How was the blood collection process? And then how was the specimen handled in getting these results? Okay, so because an error or abnormality in any of these sections could potentially give you the wrong results. So from a patient perspective here, obviously, this is a pregnant mom. So I think that's one serious consideration to take. In pregnancy, we anticipate and expect that the 1 milligram levels as well as the factor 8 are going to be falsely elevated. And therefore, this is not the right time to do the testing. Okay, so you might want to wait to see, unless this is a type 3 1 Willebrand's disease in this mom, which I doubt because she would have been diagnosed by now. We would not expect to find abnormal results during pregnancy, especially at this trimester. So that's one thing. From the child's perspective, if it takes three people to hold this child down, takes a long time to get this sample, and you have to put the tourniquet in for a long time, this stress itself can also make the levels of your 1 Willebrand factor as well as factor 8 activity go up. So those levels of 100% in this situation in the child itself may be falsely elevated in this situation. So that's one consideration to take into place. Of course, collection is, again, if you use too small a needle, if you don't get good flow, if you don't have the correct tube type, they could potentially give you either falsely elevated results or falsely low numbers as well. So things to keep in mind. From a specimen handling perspective, if this is a pediatrician's office and they draw the blood at 9 o'clock in the morning when the child walks in, and the specimen is not picked up till 5 p.m. and then taken to a lab where it's processed probably not till 8 or 9 that night, you're looking at results that are going to be falsely low. So 1 Willebrand factor activity and factor 8 activity will drop with time. So all the specimens have to be processed and frozen within 4 hours for us to get accurate results. So a few things to keep in mind, and this is what we refer to as pre-analytical variables. And it's really important to keep these in mind whenever we are looking at results for 1 Willebrand workup when we interpret them. Okay, next slide. So let's go to case number 2. Here you have a 12-year-old female who comes to the emergency room with dizziness and prolonged menstrual bleeding for 19 days. Her menstrual history is that she started her period when she was 10. Her periods last about 9 to 12 days, and they happen every month. She reports flooding, passing large clots. She often stays home from school for the first 3 days of her period because her periods are so heavy. And when you see her, or when she's seen in the emergency room, her hemoglobin is 6. She's evaluated by a gynecologist, and the diagnosis is anovulatory bleeding. She started on hormones with good response. And so this episode is kind of forgotten by everybody. And 2 years later, she has a wisdom tooth extraction and has prolonged bleeding with a drop in hemoglobin to 6 grams per deciliter again. So what happened here? What did we miss? And what could we have done to prevent this, again, episode of prolonged bleeding with wisdom tooth extraction and potential need for a red cell transfusion at this point? Next slide, please. So there's plenty of data to indicate that often symptoms are not necessarily people don't pay attention to the symptoms that people present with, especially in the diagnosis, in the setting of diagnosis for 1 Willebrand's disease. The biggest problem, I think, is heavy menstrual bleeding is often not regarded as a symptom of a bleeding disorder. There are many studies that have looked at this, and 2 years of delay is significant. One of the things is that if you look at this graph, most of the patients who've been diagnosed with 1 Willebrand's have had symptoms for a long time before they actually came in. So if you look at that first 1 Willebrand claim, 12 months before the diagnosis, there were several patients who had had 3+ bleeds, many that had 2 bleeds, or at least 1 bleed. Okay, so I think it's important for us to pay attention to all of these symptoms. A good bleeding history cannot be underscored in our history, in our diagnosis of 1 Willebrand's disease. That is one. And recognition that heavy menstrual bleeding may be one of the first symptoms that the patient presents with is another very important aspect to be kept in mind. So I just want to raise awareness to this fact that even during the anovulatory period of your menstrual history, workup for 1 Willebrand's disease is warranted, because you can still pick up people who have a bleeding disorder, because a third of these patients could potentially have one. Next slide, please. So this lack of awareness sometimes can cause significant problems. Bleeding leads to significant anemia, unnecessary hospitalization. It keeps these kids at home. They're not able to do the activities that they want to do. They lose a lot of time from school. Significant school and work absenteeism has been reported. And it's just definitely not good for the psyche of this patient as well. Quality of life is extremely poor, and this is something that is avoidable. And one of the graph on the right actually shows you an interesting aspect. Okay, so they looked at what symptoms do patients complain of and how much attention do providers give to those symptoms. And if you look at this, most people that had nosebleeds, most people that had oral bleeding or bleeding with dental procedures, providers gave it the appropriate or even more attention than the patient's complaints themselves. But easy bruising alone or heavy menstrual bleeding got less attention than they needed. So I think that means to say that we're not paying as much attention to a bruising history, and we're not considering heavy periods as a symptom of a bleeding disorder that requires investigation. Next slide, please. So only 5% of women with heavy periods are often referred to a hematologist or even get screened for a bleeding disorder. But we know that 20% of adolescents who present with heavy menstrual bleeding actually have an identified bleeding disorder. And a third of those who are hospitalized for heavy periods end up with a diagnosis of a bleeding disorder. But if we don't do this, many of them are not diagnosed till adulthood or until they have another procedure, which results in excessive bleeding. And again, like I said, the presence of anovulatory bleeding does not rule out a bleeding disorder. The problem is that we don't have specific guidelines for this population, and therefore increasing awareness is probably potentially our best way of ensuring that providers pay attention and work them up for a bleeding disorder. Next slide, please. So this is just a slide that shows what are all the bleeding disorders that present with heavy menstrual bleeding. Von Willebrand disease and platelet function are the most common, but all other factor deficiencies can also present with bleeding, with heavy menstrual bleeding as a presenting symptom. Next slide, please. So I'd like to stress on the fact that I'd like to increase awareness of physicians and patients that heavy menstrual bleeding and can be a presenting symptom for bleeding disorders. Von Willebrand disease diagnosis is hard to establish. There are many factors that have to be taken into consideration when we look at von Willebrand activity. We need good, high-quality labs in order for us to obtain the right testing. And now to stress on this fact, we have Dr. Flood taking over and talking to us about the testing itself.
Thank you, Dr. Chitler. That was a wonderful introduction to all the things that can go wrong in terms of not thinking about von Willebrand disease or thinking about it, but ordering tests in the wrong setting. So if we can go to the next slide, I'm going to talk a little bit more about the actual testing part of this process. So I wanted to, again, frame this like Dr. Chitler in the form of a couple of questions. So our first question is a young woman who presents with heavy menstrual bleeding, and you suspect this could represent von Willebrand disease. So what test should you send to assess for von Willebrand disease? And just so you know, these are completely anonymous. We have no way of telling who has answered what question. And I always think these polls are more fun if you participate, but also not judging if today's a day you just prefer to sit and listen. So if you get to the point where you have seen somebody in your clinic and you think, okay, von Willebrand disease is definitely on the differential diagnosis, I think most people are aware that you need to actually order specific von Willebrand testing because unfortunately, our screening tests that we do for things like hemophilia or other factor deficiencies, the PT and PTT, just do not capture most patients with von Willebrand disease. The other problem, as we will be talking about, is there's unfortunately no single test that is good enough. So we also need to think about looking at both the amount of von Willebrand protein, which is the von Willebrand factor antigen, and then how it works. So some sort of activity assay. And if we could go to the next slide. There are a number of tests that one can order if one is thinking about von Willebrand disease. So first of all, factor VIII, because VWF is the carrier protein for factor VIII, is an established part of the von Willebrand factor testing. The von Willebrand antigen, again, is the total protein. But since there are a number of variants of von Willebrand disease where the VWF doesn't work right, we also have tests that look at its main function, which is binding to platelets. Historically, that has been done through the test called the Ristocetin Cofactor activity assay. And that is the test that is most commonly available. We'll talk a little bit about a newer assay, which is the VWF GP1BM, or VWF binding to a mutant or a variant of platelet GP1B alpha that allows one to do the assay without any ristocetin. We also often will look at VWF multimer structure. And then I want to talk about genetics also, where we were asked to talk about genetics of von Willebrand disease, because genetic testing has become much more common as potentially a first-line test, getting one a window into somebody's von Willebrand factor function. There are a number of other specialty assays, including collagen binding, VWF propeptide, the low-dose ristocetin-induced platelet aggregation, or RIPA, specific factor VIII binding assays. But I would say the most common panel includes factor VIII, antigen, some form of platelet binding, and potentially multimer distribution, or in some cases, collagen binding. If you can go to the next slide. The reason we need multiple tests is that von Willebrand disease can be quantitative or it can be qualitative. And the antigen measures the protein levels, but it does not measure function. The qualitative defects, which is your type 2 von Willebrand disease, are characterized by a problem with the von Willebrand factor function, either a problem with platelet binding, collagen binding, factor VIII binding, multimerization, as in types 2A and 2B von Willebrand disease, and sometimes it's actually a combination of all of these. Next. So there actually is, in the 2020 von Willebrand disease guideline, a testing algorithm that recommends starting out with von Willebrand antigen, some form of platelet-dependent von Willebrand factor activity, and a factor VIII. And then depending on those results, going from there to try to figure out what type of von Willebrand disease you are dealing with. Now, I do want to say that type 1, which is the mild to moderate quantitative deficiency, is far and away the most common. The von Willebrand antigen and activity will be proportionally decreased, and the rest of this testing is not necessarily super relevant. So that is the most common thing one is going to see in clinical practice. That is most likely what the patients we've been talking about today have. And the rest of this is a little bit more intellectual. That being said, I suspect this is the group that's going to see the occasional person who menstruates with one of these less common variants. And so it's important to know they exist and to be able to interpret the results should they show up in your clinic. Next. So you've heard about the pre-analytical problems that go into this. The problems from a testing standpoint, in addition, are that there's no single screening test for von Willebrand disease. So these can be very cumbersome to order, especially if you're not sure which test measures what. And there's no simple confirmatory test. There's nothing you can send that says, yes, absolutely, or no, absolutely not. Repeat testing may in fact be necessary. VWF is an acute phase reactant, so it goes up in pregnancy, as you heard, it goes up with stress. There are some things that decrease it, like seizure medications, but most of the time we're dealing with a potential stressed situation. I will say that there's some good data out of CHOP that suggests that patients that show up with VWF levels greater than 100 units per deciliter are very unlikely to come back. Even if you repeat the testing multiple times, they are very unlikely to come back with a diagnosis of von Willebrand disease. The part where this becomes very challenging are the people with the low normal levels. So someone who presents with severe iron deficiency anemia, severe heavy menstrual bleeding, and has levels in the 60s or 70s, for example, those may be the people that you would want to repeat testing on. The person who comes in with a level of 300, you can probably stop at that point, at least with the von Willebrand disease workup. The other problem is that low von Willebrand factor is not always associated with bleeding, particularly for those of us that do pediatrics. So there is a small cohort of patients where their levels are slightly low, but they don't necessarily bleed. And then even though this is a session on von Willebrand disease, I just want to call out that there are other bleeding disorders that present with similar mucocutaneous bleeding, similar risk of heavy menstrual bleeding, including platelet disorders, some of the collagen vascular disorders. And there are people that can have multiple of these at the same time that exacerbate their symptoms. So if you don't feel that their presentation is fully explained by the von Willebrand disease, it's important to consider looking at other things. All right, next slide. So there is a new assay that looks at VWF platelet binding specifically. And since the nomenclature is a little weird, I do want to go over it. The official way we're supposed to refer to this assay is the VWF GP1BM. GP1B is obviously the platelet protein that VWF binds to. And this assay is done, at least the Siemens version, using a microparticle that has a capture antibody. They put what's shown in the green here is a GP1B with a couple of sequence changes that allows it to spontaneously bind the VWF-A1 domain. This does not use ristocetin. It uses this gain of function platelet protein. There is much less variability and higher precision, which is an improvement over the old ristocetin cofactor assay. It is still not a physiologic assay. So the way VWF binds platelets in vivo is that shear stress unravels the VWF protein and exposes the A1 domain. But it is an improvement for several reasons, and it has recently received FDA approval, so I suspect more and more people will have this available in their labs. Next slide. The assay is at least as sensitive as the old ristocetin cofactor activity, and when you're dealing with a quantitative defect, matches up perfectly. You may notice in the graph in the right panel, it doesn't match up quite as perfectly with the type 2 variants. Some of this is probably because the ristocetin cofactor activity, which was our official gold standard, may not actually be quite as gold as it should be. So, it's hard to say that your replacement assay is better, but in this case, that is probably what's going on. Next slide. And then the other issue is that there are some sequence variants in VWF that are especially popular or especially common in some populations, like those whose ancestors are from Africa. And if you happen to have, there's a particular amino acid, 1472H, if you happen to have the histidine allele, you have a much lower likelihood of, or a much higher likelihood of a low ristocetin cofactor to antigen ratio, as compared to those people that have the aspartic acid at that allele. And then heterozygotes are, of course, intermediate. Next. And then if you consider that we typically use a cutoff of less than 0.6 to diagnose somebody with type 2M von Willebrand disease, I just want to call attention to the fact that this graph is in healthy individuals. A number of these healthy individuals had ratios low enough to get them a diagnosis of von Willebrand disease. And it turns out this is just a problem with ristocetin and not a problem with the way their von Willebrand factor actually works. I think the goal of this session is to improve diagnosis of von Willebrand disease in people who need the diagnosis. One of the nice things about the newer assay is that it will also result in less people being misdiagnosed when they don't actually have von Willebrand disease. So it's exciting that we finally have FDA approval for it. Next slide. So there are also guidelines about the newer activity testing, and the 2021 guideline did suggest that the newer measures, which would be this GP1BM assay marketed as the Innovance VWF activity by Siemens, should be used over the old ristocetin cofactor assay. This was a conditional recommendation. The newer assays have lower variation and higher reproducibility. There's less risk of overdiagnosis, but they are not as widely available. So that was part of why this was only a conditional recommendation. Next slide. The FDA approval will hopefully help with that. Okay, so the last topic that we wanted to cover was genetic testing for von Willebrand disease. And again, we wanted to set this up in the form of a case, which is that of a 13-year-old who presents with heavy menstrual bleeding and a long-standing history of easy bruising and nosebleeds. Her CBC shows that she has a hemoglobin that is quite low at 8 and a platelet count of 90,000. You do von Willebrand testing on her, and her von Willebrand factor antigen is 60, and her von Willebrand factor activity is 28. And then we're just going to ask what the most likely diagnosis is, and you can put in your best guess, and then we will talk through this. Give people a moment to answer. Okay, so we have a couple of different options here. And it looks like we do have the majority of people voting for type 2B von Willebrand disease, which is the most likely diagnosis based on the fact that you have somebody with an activity to antigen ratio that is low. In this case, it's less than 0.5. So this is probably a type 2 variant, not type 1, which everyone agrees on. And then the thrombocytopenia is the hallmark of type 2B von Willebrand disease. So next slide. So this is the same patient. What is the next most efficient test to send? You are suspecting that this is a qualitative variant, that this patient has some form of type 2 von Willebrand disease, and you want to confirm that diagnosis, which is very reasonable because we sometimes use desmopressin, but type 2B von Willebrand disease would be one situation where you would not want to necessarily give desmopressin. So we have a couple different options for the next most efficient test to send. And I think the majority figured that since this is in the section on genetic testing, they would go with genetic testing, which is in fact the recommendation for how to proceed. I will say that I could have probably set the question up better, because it would also be very reasonable to document that this patient has a loss of high molecular weight meltamers. And indeed, that probably should have been part of the initial panel. But with the thrombocytopenia, if we're anticipating that this might be a type 2B, genetic testing is actually the way to go for this particular variant. So next slide. The von Willebrand factor protein is complicated, which means that the genetics of the von Willebrand factor protein are also complicated. There are a number of domains. Probably the most important one in terms of platelet binding is the A1 domain. That is where the VWF binds platelets and also some forms of collagen. And that is where the location of most of the type 2B von Willebrand disease genetic variants are. Next slide. Trying to advance it myself, and it turns out that doesn't work when I'm not controlling it. I do want to go back to type 1 von Willebrand disease for a moment. There are a number of studies, although I do want to admit these are heavily biased towards Northern European, Caucasian ancestry type patients. But of these patients who had type 1 von Willebrand disease, on average, about 2/3 of them present with a genetic variant in VWF, and 1/3 do not. So this is the reason that if your concern is, does this patient have type 1 von Willebrand disease, genetic testing is probably not the most efficient way to evaluate for that. Next. And part of the problem may be that there's a number of genes outside of the VWF locus. We have long known that ABO blood group is associated with low VWF levels. It turns out that there are a number of other proteins, most of which appear to have to do with the VWF clearance and processing, that may be implicated in some of these patients with type 1 von Willebrand disease, where we don't see a clear problem with the VWF itself, but we probably also haven't discovered all the factors that are an issue. Next slide. The nice thing, though, about type 2 von Willebrand disease is because these are qualitative problems in the way the VWF works, they are very nicely linked to those areas of the protein where it's dysfunctional. So type 2b localizes to the A1 domain. Most type 2Ms, which are the von Willebrand disease where there's normal multimers, but otherwise it doesn't work, those are in the A1 domain with a few collagen binding defects in the A3 domain. Type 2A, which is a defect in multimerization that does not have the gain of function platelet binding that type 2B does, those are located in areas important for multimerization. And then type 2N, which is a defect in factor VIII binding, is very nicely localized to the factor VIII binding domain, which is the D' D3 region of the VWF. So for type 2 variant, sequencing can be very, very helpful. I will also acknowledge, because I don't think we talk about it again, type 3 von Willebrand disease, those variants are also all over the place in the VWF gene. That being said, I really don't think that diagnosis of type 3 is a diagnostic dilemma because you're going to get no protein on any of your assays. So generally that is not in question. Next slide. So it is nice that we have some guidelines on genetic testing, and actually the guideline was specific for two, type 2B and type 2N. So there are a number of different tests that can be done to diagnose type 2A versus type 2B once you've seen that loss of high molecular weight multimers or the low collagen binding. The guideline panel did suggest targeted genetic testing over these other assays like RIPA, or ristocetin-induced platelet agglutination, to diagnose type 2B in patients with type 2B or 2A in need of additional testing. And again, the reason is because this has relevance for their prognosis and treatment. And so genetic testing is recommended when available. And part of this is because the general contraindication against desmopressin. Again, there may be experts in this audience that will occasionally use it carefully in these patients, especially if it doesn't drop the platelet count. But for the broader audience in general, it's contraindicated in type 2B. Next slide. And there is in the guidelines paper, which everybody should be able to download from Blood Advances, but if you have any trouble, please let me know. There is a nice algorithm for this. And there's really only a small handful of type 2B variants. So if you do the genetic testing and pick up one of those, you're good. You've made your diagnosis and you can go relax and go on treating your patient. Next slide. There is also a recommendation around testing for type 2N von Willebrand disease, which is that the panel suggests using either a factor VIII binding assay or targeted genetic testing for patients with suspected type 2N. Next. Because again, this is another condition where accurate identification is very important. This can sometimes be confused with hemophilia. So not missing the diagnosis was of the highest value. There's advantages and disadvantages to both types of testing. They are both send-outs. They are both likely to take a while. So really here, the idea is make the diagnosis however you can. Next slide. So I just wanted to wrap up with some reasons why or why not to do genetic testing. And in the why column is that it may be more cost effective, especially now than multiple plasma-based assays. When there's known causative variants that show up on your genetic testing, this confirms your diagnosis without too much more delay. And it may help determine the necessary treatment. So particularly when you're looking at someone who may have type 2 von Willebrand disease, this can be very efficient. Next slide. I do think though, and my genetic counselor colleagues would probably say I would be remiss if I did not point out that there are also some problems with it. There are these variants of uncertain significance, which I think many of us have dealt with, that when they come up, they are completely not helpful. And we also know that there are some variants in von Willebrand factor that do not necessarily cause disease. We should also be careful to acknowledge that genetic testing may have implication for the patient's family members. So I really think in the bottom line here is that this is most helpful in type 2 von Willebrand disease when the exact subtype is questionable and you're really trying to narrow down what this is. the most common situation, which is somebody with borderline von Willebrand factor levels that you're trying to decide, does this person have heavy menstrual bleeding because of type 1 von Willebrand disease or because of some other etiology? That is exactly the place where genetic testing is going to be least helpful and probably where we need some simple assay the most. But I will also let Dr. Chitler chime in with her opinions. And I think that is the last slide of our content. And our goal was to leave plenty of time to have a conversation around any of these issues or other issues. So.
Thank you, Dr. Flood, for a wonderful talk. Can I start with a question myself? Do you recommend that we do both GP1BM assay as well as collagen binding when we send the testing? Or as the algorithm recommends, should we start with the GP1BM first and only consider collagen binding if we want to look at type 2? I'd like to get your opinion on that.
Yeah. There is arguments pro and con, obviously. There are very rare variants that can affect VWF binding to collagen alone and not affect platelet binding. I think, though, generally speaking, you're going to pick up, again, the vast majority of patients are going to be type 1 with slightly low levels. And in theory, those are the patients that you could get away with doing one of the assays and not multiple. So the most cost-effective way to do this is probably to do the factor 8, the antigen, and some form of platelet binding activity and see what you get. The likelihood that this is actually bleeding due to a platelet disorder, if all of those come back normal, is probably higher than the likelihood that it's due to a collagen binding defect. But if you're also trying to most quickly get a diagnosis, having multimers or collagen binding to be able to pick up those 2A or 2B subtypes, you could argue that it's more efficient to include them in the initial panel. So I don't know that I have an answer. Probably the cost effectiveness experts would recommend we not do that on the initial pass. And I think it depends on how severe the bleeding is. So we certainly see, and I'm sure you do too, lots of people that the issue is raised because of some very borderline bleeding symptoms. But as you so eloquently pointed out, there's also a lot of bleeding that we probably aren't paying enough attention to. So that's really, I didn't answer your question because of course I can't.
Thank you. That was I think a good way to think about it and know why we are looking at the collagen binding assay versus just sending it as a panel. So that was very helpful. Thank you.
So at this time, we just want to open the question and answer portion up to everyone who's joined us today. Please just either unmute yourself, open your camera, and feel free to ask a question, or if you have a comment on anything that these excellent presenters have put forth today, please join us in a discussion.
So I'm going to take the opportunity then, since Dr. Chitler did this to me, to ask her. I think the slide you showed about medical professionals failing to recognize the severity of some of these bleeding symptoms was very impressive and very disturbing. Do you have any idea why that is, that we are so attuned to, for example, postoperative bleeding, but ignoring some of this easy bruising and heavy menstrual bleeding?
That's a really good question. And I've tried to get a better understanding of that myself. I think one of the reasons that I feel is heavy menstrual bleeding is considered, or menstrual bleeding is considered a hormonal issue, not a bleeding disorder issue. And I think until we can bring together the attention to the fact that, yes, your bleeding in your period is physiologic and hormone related, but if you have an underlying bleeding disorder, it only makes it worse. If that understanding comes to play, I think we will be better at recognizing heavy menstrual bleeding as a bleeding symptom versus, not. I think that's one thing about heavy menstrual bleeding. Why is bruising not considered a symptom? That is a really good question. And I think it's important for us to also understand that children, you and me know this very well, that children don't have very many challenges. They have not, most of the time, even if it's a girl, they haven't delivered a baby, they haven't had any surgeries, they haven't had any reason to bleed. And the only bruising symptom you might see is bruising. And I think bringing attention to the fact that bruising may be the only symptom you're going to see in a younger child that should still warrant a workup for a bleeding disorder if significant is the thing to pay attention to. I see there's a question. Can I read it out? Okay, if a patient comes in with heavy menstrual bleeding, but is already on OCPs, do you suggest taking them off OCPs to get an accurate von Willebrand testing, knowing that bleeding will usually get worse off OCP? What is the best way to diagnose von Willebrands in this group of patients? I can take a first stab at it, and then I'll let Dr. Flood do the rest. So there's enough data now to show that if the estrogen content in the OCP is 30 micrograms or less, that it does not affect the von Willebrand levels themselves. And therefore, if you have a patient who's on a standard dose OCP, you should be able to do testing and still establish a diagnosis. And so you shouldn't have any issues. I do not recommend that you take them off the OCP just to establish a diagnosis. Now, I'll like to see what Dr. Flood has to say.
No, I absolutely agree. I think this is something that I've seen happen because people think it's going to get them a more accurate diagnosis. And I think for various reasons, one being the quality of life of the person who has the heavy menstrual bleeding, that this is a very bad idea. And again, there's good evidence that our standard dose OCPs do not change the von Willebrand level. Stress of having an amazingly heavy menstrual period certainly can. So I think, again, if you have borderline levels on that first run, especially if it's when they initially present, it is very reasonable to repeat them once the patient is stable on a regular dose of hormones. So, occasionally we have girls that present with uncontrollable bleeding. And so we'll do estrogen 3 times a day and then twice a day. I would wait till they're done with the taper to do your repeat testing for sure. But once they're on a stable dose, you can do the testing. And again, von Willebrand disease is certainly very common in people with heavy menstrual bleeding. And people with von Willebrand disease are very likely to have heavy menstrual bleeding, but not all heavy menstrual bleeding is von Willebrand disease. So if you have multiple normal levels and you think it's pathologic bleeding, that might be the time to start looking at, does this person have a platelet function defect? Is this person actually a hemophilia carrier? What am I missing? Again, we're centered on von Willebrand disease here, of course. So that is our favorite diagnosis, but there are others.
If there's no other questions in the chat, I'd like to bring up one more question that I get asked a lot by my colleagues here who do both heme and onc. The question about when we understand that if a person is bleeding very heavily, that the levels may be falsely elevated. I know we discussed the 100% issue, but the question is, in the ER, should we be even testing them for von Willebrand's disease at that point, or should we wait till they come back and see us? I get this question all the time. I'm curious to hear what your thoughts are and what you do at your center.
So there's actually a little bit of data on this, as you know, because I think you're feeding me this question out of Emergi, that suggests that you can potentially make the diagnosis on those ER labs, and that particularly, so what I'm talking about right now is the population of adolescents who present with heavy menstrual bleeding. There's a very high risk of loss to follow-up. So that would be the reason to get the labs on the initial visit, because if you make a diagnosis or are highly suspicious of a diagnosis, if the person's coming in hemorrhaging and their von Willebrand factor level is 52, that would be somebody I'm much more concerned about than the woman who comes in with her level of 310. Then you've got some information and you can proceed. I think if you're doing this again purely from what is the most cost-effective strategy, one could argue that it may be more cost-effective to wait for the follow-up. But particularly in the adolescent population, there's a high likelihood that that follow-up isn't going to happen. And we know that for a lot of these persons who menstruate, the care becomes very fragmented, going between your pediatrician and then maybe your OB and then a family practice doctor. And so I think there is something to be said for getting the labs when you have the patient. And then if you think perhaps they need to be repeating it. But what do you guys do in Detroit?
We do exactly the same thing. I tell people all the time that I'd rather catch the one patient, that has a 40 or 50%, even when they're actively bleeding, and make sure that they get, the follow-up that they need, instead of waiting for everyone to come back and missing this patient who doesn't show up in your office.
And I think your second case, whichever the one with the wisdom tooth bleeding, I think that was the second one, was really illustrative of why we do this, because, you can probably treat their heavy menstrual bleeding with hormones. Yeah. And they may be completely asymptomatic. But then what happens when they go to get their wisdom teeth out, or many of these women continue to have bad bleeding after childbirth, and then somebody's recommending a hysterectomy and all sorts of other things, or their child needs a procedure and has inherited low VWF and has a high risk of bleeding. So I think that's my argument for why it is important to know what the cause is, even if your first line medication does an adequate job of treating it.
That is such a good point. And many times, in the younger child, when you're diagnosing them and their only symptom is bruising, I always stress upon it for the parents to say, I understand that your child does not have any life-threatening bleeding at this point. But the reason you want to establish this diagnosis and know is so that if, God forbid, he needs neurosurgery in next week, at least you know how to take good care of it and make sure you prevent any further bleeding complications. So I think that's a very important point that you brought up. And yeah, I should have said that when I had it on the slide, and that was the reason I put it there. And I think that's a very important, educational piece for parents when they come in and want to know why they need to do this testing.
And then it also ties in with the quality of life, because again, like we're ignoring symptoms. You say type 1 is a mild to moderate quantitative deficiency of von Willebrand factor. Well, yes, but the symptoms, particularly the toll that heavy menstrual bleeding takes on these people, is significant. And that's what I hear over and over again. So having things we can do to intervene.
I think school absenteeism is impressively high in this population. And I think it's so important to stress on our patients that iron is not just necessary for hemoglobin. It's actually necessary for our brains to work well. And there's enough data that we all know about that you drop a few IQ points when you are chronically iron deficient. And that is a preventable thing in our school-age population. And we should take the opportunity to make sure that we don't let that happen.
So we still have just a few more minutes. If anyone has a question, please share it with us before we wrap up. We just have a few more minutes if you want to take advantage of these two experts here today.
I see one question that'll be perfect for Dr. Flood.
So this is a great question about patients with bleeding symptoms and collagen binding that is low, less than 30, with normal Ristocetin cofactor and normal von Willebrand antigen. So yeah, there are rare patients out there that have an exclusive collagen binding defect. And this can cause more bleeding than you would expect based on just what the VWF level is. Generally, if they have normal multimers, we would throw them into the 2M category. I think the other problem is that occasionally you'll get a borderline Ristocetin that if we had a better assay or had done the GP1BM, you might see that the Ristocetin is low too. So those are actually one of the categories where you may want to consider doing genetic testing to try and narrow down exactly what bucket this falls into. But yes, those we would consider as von Willebrand disease. And I think that's one of my pet areas, because I think we are underdiagnosing some of these patients. But yes, we would consider it von Willebrand disease and treat. And I think the big question is, do they respond to desmopressin or do they need factor?
So as a follow-up to this question, if the multimer analysis is normal and your genetic testing does not identify a 2M mutation, where would you put these patients? In which bucket?
Yeah. So I don't know that I've had one yet that hasn't had a variant. It depends on what type of collagen you're doing, but there's a if it's type 3 collagen, there's a fairly, in the uncommon section, there's a fairly common genetic variant that was originally published, I think, out of a French group at position 1731 that has come up a few times. And it's one of these that seems to be associated with borderline levels, but then this significant discrepancy in collagen binding, and that has been considered to be a type 2M. It's an interesting question if you didn't find a variant, though, what you do with it. And we could probably argue about that all day. We should have a poll question on that.
That'd be cool.
I mean, by definition, and I joke about this, but I feel like 2M is the wastebasket of von Willebrand disease. So it, if they don't have abnormal multimers, that's probably what you're stuck with.
That's right.
Anyone else want to throw a question in the chat or be really brave and unmute? Otherwise, you're welcome to hit us up with questions later.
Yeah, you can always reach out to us. We're always available.
So this is Angelina. I may ask one. I mean, we've heard from patients who, just go through such frustrations over obtaining their diagnosis. Are there any messages that you've given that, helps them with the patients that's required to go through this process?
That's a really good question. I think I would like to say that I want you to be persistent. Mm-hmm. I want you to present to your physician how serious you are about these symptoms. Okay. And seek, I would take as much objective information as you can about your symptoms. I think that is key, because if you can catalog how many nosebleeds you've had in a month, or if you can download the Sisterhood app and actually document what your period looks like, then your physician is bound to, I think, hopefully pay more attention to your symptoms. So what I would like to say is I apologize for the fact that we ask you to do all this stuff in order for us to take good care of you. But I hope that by providing the physician with more objective information, then they are more likely to take your symptoms and say, yes, this sounds like it's something I need to do a workup for. And also maybe directly ask the question, could I have a bleeding disorder? Is this something that we should test for? And I don't think in this day and age that physicians would have a problem with hearing that question. That'd be my thoughts.
Great. Well, I just want to, on behalf of NHF, sincerely thank Dr. Flood and Dr. Chitler for their excellent presentations, and thank you all for joining and participating today. I think you saw in the chat and online that if you're interested in obtaining continuing education credit, an email will be sent to you within the next 36 to 48 hours. Please check your spam and junk folders. The email will come from unmc.edu as the root address, and they'll have information on how to receive your credit. Another thing I want to add is that this is the first in a series. So our next event will be on shared decision-making among women and girls and people with the propensity to menstruate. That date will be announced shortly. We'll post it on our website as well. And then look for April 2023, where we'll be talking about treatment across the lifespan. And in May of 2023, we'll be discussing complications during pregnancy and delivery. So I hope you will all join us again for the next installments, and thank you again. Please enjoy the rest of your day.